Dr. Ma, how are you?
I'm good, Dr. Hugh. How are you? This is episode 10,
10.
right?
We called it Sam and Tiff Talk Science, but maybe we should have called it Dr. Sam and Dr. Tiff Talk Science.
Yeah, just to emphasize our degrees that we spent too many years on.
I made a TikTok video of me and you messing around about how we talked about having PhDs from Oxford.
I saw
and
that.
Someone commented
saying
I deleted it because I found it rude. They said, why does this look AI generated?
Really?
Yeah.
I think that's a compliment.
Is it? And
Yeah.
I thought it's not. It's literally just me and you. What? It's not AI generated.
That's actually such a compliment.
Why? Because
it looks
it
so
looks
good that like we're
flawless.
AI generated.
Maybe. Yeah. Okay. We'll take it.
I'll take it. I take that as a compliment.
Is the sun going to come back?
Hopefully it does. It's supposed to be summer.
It's meant to be summer.
Anyways, hi everyone. Welcome back to another episode of Sam and Tiff Talk Science, episode 10, I believe. And today we'll be talking about the scientific and medical breakthroughs from June 2025, officially summertime.
Yes, finally.
And
you've
as
been...
intros.
Oh, yes.
Yes. I'm your co-host, Tiffany. I finished my PhD in oncology at Oxford University, where I met Sam. We were doing our PhDs together. And now I'm part of two biotech startups. One is a cancer vaccine spinout from the university called Immunotherapy, and the other one is a startup called Gambit Bio I co-founded with my friends, where we're using saliva as a way to detect cancer early.
Very good. I am Sam. I met Tiff when we were doing our PhDs. I am a medical doctor and a scientist and I do some other things as well.
He's a man of many talents.
So, Tiff, I want to hear about your conferences.
Right. Yeah, so I just came back from traveling like crazy, never doing that again. 9 flights in a month. I went to ASMS, that's the American Society for Mass Spec. I went to Bio in Boston and Dark Genome, also in Boston.
So ASMS, what does that stand for?
Yeah, American Society for Mass Spec.
Okay.
Yeah, so that's a nerdy scientific conference with like 20,000 people.
How was it?
Incredible. The TLDR from that is that the mass spec machines are, being upgraded every year. I really think we're reaching an inflection point in mass specs, and it's really exciting. And the ones I'm most interested in are upgraded every year, like an iPhone. Like every year there's like a new feature, and like you have to keep up.
Do you have to buy a new one, or can you do like a software upgrade?
You can upgrade the hardware part. So it's usually just like one part of the mass spec being upgraded, and you can like talk to your vendor and get upgraded, especially if you have a recent version. But sometimes like if you have an older version, you can't upgrade anymore.
And the reason you went is because of you're part of the cancer vaccine company.
Exactly.
And just tell us briefly what's the relationship between cancer vaccines and mass spec?
Yeah, so a lot of target discovery in cancer vaccines, immunotherapies, oncology is reliant on mass spec technologies. And that depends on how good you do your target discovery, may depend on like which machine you pick and how you use the machine. So that's what the conference is all about.
So it's super important for making sure you get the right target for the vaccine.
Yes, exactly.
Right? Yes.
You want to discover, in the vaccine's case, you want to discover what's on the surface of the cells, what's being presented. And the only way to do that right now is through mass spec.
Awesome.
Yeah. But how have you been, Sam? I haven't seen you for a month.
I've been good. Should we get into it?
Yeah. So you want me to start with the...
Yeah, you start.
All right. So breakthrough number 1 is this really interesting piece that Sam found from ASCO. And ASCO stands, sorry for the acronyms, biologists and clinicians love acronyms. ASCO stands for American Society for Clinical Oncology. And this year they held a conference in Chicago in June. And this is a really interesting randomized phase 3 trial of how the time of day that you receive this infusion of immunochemotherapy can affect your risk of survival or recurrence, which is really interesting. So it turns out that if you get your treatment early on in the day, then you have a much better chance of survival in cancer. And specifically, this is for late stage, stage 3 to 4 non-small cell lung cancer. It was an incredible study, and like it was very viral on Twitter, right?
Yes.
Or X.
Yeah. So, and it's a whopping effect, by the way, as well. So roughly doubling of survival. So what they had, right? So they did, so two groups. Either you had your therapy, so mainly it's to do with immunotherapy in the morning, or actually before 3 p.m. So you have the start of the infusion and finish the infusion
Before 3 p.m.
Before 3 p.m. Or second group, start and finish after 3 p.m.
Exactly.
And those who had the infusion earlier had a doubled survival.
It was 11.3 months progression-free survival, which is the primary endpoint of the study. And that was in the early pre-3 p.m. group versus 5.7 months of PFS for the post-3 p.m. group, which is insane. That's like a really striking effect.
Exactly. It's like adding another drug to the regimen. But it's not another drug. It's just doing the therapy at a different time of day. And we should say that this is, there's been lots of kind of retrospective, non-randomized studies that have looked at this, and they found the same thing.
But then they wanted to do a proper prospective, randomized, controlled study, RCT, to prove it, to get this. You can explain this to me. It's an evidence. No, I'm confusing it with another study. But this is like direct evidence.
Like level 1?
Yes, level 1 evidence. It's the same thing, right?
Yeah,
Can you explain what level 1 evidence is?
I think they just mean like randomized. So, okay.
Yeah.
So this is of absolutely central importance if you're going to talk about science and medicine. The randomized control trial is the absolute gold standard, right? And we can talk about why in the context of this study. So if you look at two groups of people, one of whom can get their therapy in the daytime and one of them who can't, and then you look who does better survival over the next few months, those two groups might be fundamentally different. So the ones who can go in the daytime, maybe they're going in the daytime because they can. So they work a different kind of job, and therefore they can leave work to go and have their therapy in the daytime, and that might be the reason that they live longer.
And not because they're getting it earlier.
Exactly.
Yeah.
Whereas if you randomize it, you isolate the effect of the intervention. So you isolate the effect of the time of day treatment. And that's completely essential to figure out. So you remove confounders, you get rid of confusing things.
So the key word here is randomized, because by randomizing it, then you get rid of all the potential confounding factors.
So you're randomly splitting two groups. They're the same, right? So you've got two groups of people. They're effectively the same. They're randomly split. The only difference is time of day.
Yeah, that's brilliant.
That's why it's so important.
Actually, in this study, they also say that the results were irrespective of PD-L1 status, which is quite important as well because, usually in non-small cell lung cancer, clinicians stratify the patients by their PD-L1 status, whether or not they express this programmed death ligand, and whether or not to give the immunotherapy after that. But here they see that it's not dependent on PD-L1 expression. It's literally the time of day factor.
Mm. Yeah, exactly. And in terms of the mechanism?
Yes. They had some hypotheses. So the primary endpoint was progression-free survival, but for secondary endpoints, they also looked at overall survival, and they also analyzed the lymphocytes in the whole blood of the patients. And there were two key takeaways from their T cells. The first is that there was an increase in circulating CD8 positive T cells. So these are usually the cytotoxic killer cells that kill your tumor cells. They find them in your body. There were more of those T cells in the early infusion group pre 3 p.m. compared to the late one. So that's a potential hypothesis for why that group has better survival. Though my caveat as a cancer vaccines person would be like, I would like to know whether or not those T cells are tumor antigen specific.
Yes.
Because that would be like, kind of direct evidence that that the immunotherapy was more effective.
Yeah, exactly.
But yeah, that's promising piece of evidence. The second piece of evidence is that they measured something called the activated versus exhausted T cells ratio. And basically, these are two types of T cells. One that's like, you can imagine is very active and good at killing your tumor cells. And the other subgroup is they're kind of tired. They're like hanging around the tumors, but they're not doing much. They're a bit useless at that stage. And obviously you want the good type of activated T cells. And I found that like there were more of those in the early group. The ratio was greater in the early group compared to the post 3 p.m. group. Yeah.
And I guess underpinning those mechanisms is this circadian nature of the immune system, which is fascinating, right?
Yeah, I know nothing about that. You probably know more about it because you're in the medical world.
so I mean, everything we do pretty much is regulated by the time of day, right? And the immune system is no different. And it turns out that circulating T cells, so the T cells that you're activating with the PD-1 blocking immunotherapy, peak somewhere in the morning or in the early afternoon. They're higher then, and then they go down. So the people who had the treatment, the PD-1 blocking immunotherapy in the morning, had more T cells to engage with their immunotherapy. And that's potentially why they did better than the other group who had lower levels of T cells in the afternoon.
And it's crazy because it's such a small, like acute change, but you can still measure the changes like during the follow-up period. So like it really goes to show like timing matters, like even if it's just a few hours apart.
Exactly. Yeah. And slightly confusing, and lots of people said this, slightly confusing is that the PD-1 blocking immunotherapy that you use has a half-life in the weeks. So if it's got a half-life in the weeks, how is it having such a staggering difference between two groups that are split just by hours?
Yeah,
so,
how?
But it's possible that the first time you get the infusion is the most important time, and that kind of sets the tone for the rest of it, even though the antibody then sticks around roughly at the same level for the next 2 or 3 weeks.
Yeah. I think that makes sense from a, scientific point of view, like from a kinetics point of view. Like, how like in like GCSE chemistry, you learn about like the activation energy. Like if you have enough of that thing at the beginning, you can really get that effect. And I think, that's why the presence of those like activated immune cells at that time of the day, maybe that makes a difference in how it reacts with the antibody.
Yeah, exactly.
Yeah.
Other interesting things. So we're assuming that the patients in the study had a kind of normal daytime sleeping routine, right? And that's maybe what's driven the T cells to have their fluctuation throughout the day, and that's what's driven the effect. But what happens if you're a night worker, or if you're someone who sleeps late, or
that's a great
has
question.
a different circadian rhythm?
Like mine.
Very
messed up sleep schedule, basically.
It could be that not only is it circadian, but that it's also personalized, and we should look at each person's individual circadian patterns before we figure out which time of day to give them the immunotherapy.
Yeah, absolutely. I wonder like if they took blood at the time of infusion. Probably not, right?
At the time of the initial infusion?
Yeah.
I don't know. So the other thing about this study is it's not published.
Oh yes, this
means,
was like announced, interim results announced at the meeting at ASCO. So this is not a
So it's difficult
paper.
to know exactly. That's a pretty major caveat, but it's pretty difficult. But people are pretty bullish on this idea. I mean, I saw, people who are doing this kind of therapy, oncologists who do this therapy saying, if it were me, I would want the morning slot.
Yeah. Because they've seen the pattern in multiple contexts.
Exactly.
Oh,
So
you know what
so
this reminds me of? Sorry, this is not science related.
Go.
Do you remember the Hungry Judge study from like 15 years ago?
No.
This isn't like, a board of people looking at like for parole for prisoners.
Oh,
and then like
and they give a harsher punishment at the end of the day when they're
yes,
hungry.
exactly. And if it's early on in the day, you were like however many times more likely to get parole.
That's crazy.
And then like it drops to 0 as like the judge gets more hungry. And then after they eat, like it goes back up again and then it drops again. So it reminds me of that.
Hungry.
Yeah. Hungry Judge study.
Yeah.
Anyway, sorry, that was a distraction.
No, that's a good point. That's a good point. So yeah, I mean, what do you think? What are the takeaways, or what should we be?
Yes. But just to say one last thing on the safety profile, there was no significant difference in the high grade adverse events between the early versus late group. But yeah, the TLDR is, patients' circadian rhythms and their sleeping habits should be examined so then they can be stratified before receiving these immunochemotherapies because it's obviously making an effect. Even though caveat, this needs to be published.
Yeah.
Yeah.
I mean, because at the moment, we like guidelines and so on. People come for immunotherapy when there's a slot. They don't come. We don't think about the time of day at the moment. But this study very strongly suggests that we should, and not only should we think about it, but actually we should be just putting people in the morning slots, or indeed if they're a night worker, then you switch around somehow. But,
as a clinician, how long do you think that will take to implement officially into the clinical pathway? Yeah.
I think you could, so that you would need to see the full study first. They may want to see a replication in order to change everything. They'd probably want to see a replication. You want to see it in subgroups, in the night workers and so on, in different types of people, in men versus women and so on.
And then the NHS will consider it.
Yeah, but then of course you have to build in the infrastructure. You'd have much more people coming in the morning. It gets a bit complicated, but I don't see why it wouldn't be able to happen, assuming this is all real and true in the next 1 or 2 years.
That would be amazing, game changing.
Yeah.
Wow.
I love the idea of these therapies or these kind of changes to therapies where it's like the effect is like you're adding another drug, but you're not.
You're just changing something so simple, seemingly simple.
Yeah.
Yeah.
That's really fascinating.
It's even more effective than some drugs.
Oh, yeah. Yeah, exactly. And usually if you add another cancer drug, you also add a bunch of side effects.
Yeah.
But there's no extra, like you said, there's no extra side effects here.
It's literally just waking up earlier and getting the infusion earlier.
Yeah.
Mad. Awesome.
Okay.
What's next, Sam?
What a breakthrough. Okay, next we are going to talk about what is moving towards a cure for type 1 diabetes. Exciting. And lots of people said this was a cure, and there was some pushback because it's not really a cure.
All right, as background, what's the difference between type 1 and type 2 diabetes, just for the audience?
Yes, so type 1 diabetes is an autoimmune condition, usually has an onset in childhood, very strongly genetic determination plus environmental triggers too. So often there'll be a viral trigger, for example, that then causes autoimmune destruction of the cells in the pancreas that produce insulin.
And right now it affects 8 million people worldwide.
It's very common.
Yeah.
It's very common. And Theresa May, the former Prime Minister of the United Kingdom, had type 1 diabetes, for example. It's very common. And it causes an absolute... you can't make insulin at all. So you have to then take usually injections of insulin, or you can have like an artificial pancreas where you get like continuous infusions of insulin.
Both very not ideal.
No. And both of them, we'll talk about this of course, but both of them are, so you'd have to do a lot of injections, but even then it doesn't do a great job of controlling glucose. The other one, type 2 diabetes, is usually more later in life, also has a very strong genetic component, but the main driver is obesity. And it is characterized not by a loss of insulin production, but by insulin resistance.
So like your cells lose sensitivity to insulin, basically.
Yeah, exactly.
Probably have, I don't know, too much sugar.
Yeah. Yeah. So exactly. And so it can be treated with insulin, but much later down the line. Usually you use something like metformin would be first. Also things like Ozempic, right? GLP-1s are really good, and other ways to control blood sugars. But so those are the two different types of diabetes.
But in type 1, basically your own body is destroying the cells that make insulin,
Yes.
which are the beta cells in
In the pancreas.
Yes, in your pancreas.
Yes.
Yeah.
Exactly. Which is where this comes in. So there's two issues really with most type 1 diabetics would use insulin. Like I said, so usually they just inject daily insulin. But the two issues with that is, one, often it doesn't do a great job of controlling glucose, even though you're giving insulin. Two, there's a second issue in type 1 diabetes, which is called hypoglycemia unawareness. So you have really low blood sugar sometimes.
That's really dangerous.
And you don't know. So if you had low blood sugar now, you'd know, right?
Yeah.
You'd get jittery, you'd feel weak, you'd feel bad.
You crave chocolate.
You would crave chocolate, you would know. Whereas type 1 diabetics would get really low, dangerously low levels of glucose, and they wouldn't know. And then, that can be quite dangerous.
And that's really dangerous because it can lead to things like comas and what else? Like just life-threatening
seizures. Yes. And, passing out. You don't want to, go for a drive, for example, and have low blood glucose and then pass out. That would be.
Oh, God.
So those are the main issues, which is why then we have really two ways to fix both of those issues at the same time. One is an islet transplant from a donor. Two is a pancreas transplant.
Both of which are not very scalable because you don't have enough donors.
Exactly.
Yeah.
Exactly. So pancreatic transplant is a very major operation. Usually it sits in the kind of front of the abdomen.
It's really deep. Like pancreas is quite deep,
you put in a second one. So you leave the native pancreas in and then you put a second one.
I didn't know that.
Yeah.
Wow.
Same with kidney. So you don't take, if someone has a kidney transplant, you put in a new one. So they would go usually down here or here. So you could feel it.
Wow. So you end up with 3 kidneys?
Yes, or more. Some people have like 5, 6, 7 kidneys.
I did not know that.
Yeah. Wow, right?
Oh, wow.
But the other interesting thing about the islet or islet? Don't know.
I say eyelids, but
okay.
English is not my first language.
The other interesting thing about the islet transplant is that it doesn't go on the pancreas. So the islets come from the pancreas, but the transplant doesn't go on the pancreas.
Where does it go?
On the liver.
What?
Yeah.
This is crazy.
Interesting, right? So what you actually do is you pop it in, you have to, it takes a specialist doctor, you pop it into the islets, into the portal vein, which then goes onto the liver. And the islets sit on top of the liver.
Yeah.
Which is a good place to go because it's got loads of blood supply and liver cells love taking things up and having things stuck on them and so on. Pancreas would get irritated, and you can actually get things like pancreatitis.
Yeah.
Which is
unwanted inflammation.
Exactly.
And it's probably easier to access the hepatic portal vein.
Precisely.
Yeah.
Much easier to access. Exactly.
Great.
So
what do they have here that's so life-changing and groundbreaking?
So like you said, so those things aren't scalable. So you need a donor. But what would be scalable? Stem cells.
And these are pluripotent stem cells.
Yes,
right?
exactly.
Yeah. And this is a allogenic one, meaning that it's from a donor. So it's not your own cells. It's from someone else's cells that's been edited.
That's right. Exactly. So pluripotent stem cells, which what that means is they can differentiate into any type of cell they want to, including islets. So you take the stem cell line. It's like you can just grow it in the lab, right? We used to do that all the time. You have it in the lab, in the incubator, and it just grows and grows and grows and grows. Or you can pop it in liquid nitrogen or whatever you want to do with it. And then you can differentiate it into islets, and then put them onto the liver. And it turns out in this study, that's exactly what they did. And they had 10 of the patients which were effectively cured of type 1 diabetes. In other words,
this is a small cohort. They only had like 12 or 14?
12,
12 patients. Yeah. I saw that the amazing thing was these new transplanted cells were making enough insulin such that big portion of these patients don't need to do the
Yeah.
injections anymore of insulin.
Yeah, precisely. So it's amazing. So they have this stunning figure where they look at baseline levels of insulin and it's nothing. None of them have any insulin at all, which is expected. And then they have the islet transplant, stem cell derived islet transplant, and 10 of them were able to produce healthy, normal levels of insulin without taking any injected insulin on top. That's why it's effectively a cure.
That's
Here
amazing.
come the caveats.
All right. What did the haters say?
So one take I saw was that there was a patient with type 1 diabetes, and he said, this isn't a cure because if I have to take immunosuppression for life, it's not a cure.
That is a huge caveat. We forgot to say they had to take
right.
immunosuppressants because, as I mentioned, there's an allogenic therapy. It's not from you. It's not your own cells. It's from a donor's cells, which means in order for your body to not reject the therapy, you need to take immunosuppressants.
Exactly.
So it means they couldn't take glucocorticoids. I can't say that word. But it's a form of steroids that acts as an immunosuppressant.
Yes.
Yeah.
Yes, exactly. So if you take immunosuppression, you are at risk of infections. That's the main issue.
And that was related to the 2 other patients out of the 12 that, I think did they die?
There were 2.
Oh gosh.
There were 2 deaths in the trial.
But apparently it was unrelated to the therapy and more to do with.
So the patients that were the patients, unfortunately they did die for reasons unrelated to the therapy. One of them had dementia, for example.
Another other one had meningitis.
Yeah.
Yeah. So, but it was still unrelated to the therapy, and these things happen in clinical studies, which makes them so complicated.
Exactly.
Yeah.
So this therapy, because of the need for immunosuppression, this therapy isn't going to be for everyone. But there is a patient group in diabetes, type 1 diabetes, that could benefit from this therapy because they're already taking immunosuppression, and that's and that's people with kidney transplants. So lots of type 1 diabetics get kidney transplants because type 1 diabetes can cause kidney failure ultimately. So you have a kidney transplant to fix that. And those people are already taking immunosuppression. So you could envision that cohort of patients to have this therapy.
That's great.
Indeed,
it's like a no-brainer.
Exactly. Yeah. That is kind of already what we do at the moment with combined pancreas and kidney transplants, which is what happens at the moment. So you get a kidney transplant and a pancreas transplant to fix both issues, but maybe in the future you get a kidney transplant and a stem cell derived islet transplant to fix both issues.
Because then you don't need the pancreatic transplant.
Yes. Yeah. Yes, precisely.
It gets rid of the need for donors. So that's great.
Exactly.
And it's really, I think this is game changing.
It is. And the other thing is that I was talking about hypoglycemia unawareness at the start.
Yeah.
So this therapy would, or at least if you get an islet transplant or a pancreas transplant, those do increase your awareness of when you have low blood glucose. That's really important. So this probably will too. I don't actually know if they check that, but it probably will.
That's really interesting. That kind of suggests that like having those functioning cells will kind of allow you to become more aware.
Yeah. Yes. Which is really important.
Of course, because like I can't imagine like not responding to your body's like needs.
Yeah, I mean it's totally fundamental, right? Like glucose is completely fundamental at all times.
But it must be because of the baseline. They're so used to it that they don't.
That's right.
They're not aware of it.
Exactly. So you get your brain or your brainstem develops like is not aware of changes in glucose, and therefore exactly.
Wow. I just wonder like if this is what pluripotent stem cells therapies can do for type 1 diabetes. I just wonder what other diseases can benefit from such a therapy, cell therapy.
Yes.
Yeah.
Exactly. Do you have any in mind?
I'm just trying to think of other regenerative like diseases.
I've seen it in Parkinson's. for
There you go.
dopaminergic cells in Parkinson's.
Yeah.
What else? Can we think of any others?
Gosh, I just put us on the spot, but I'm sure there are many others. It's just very encouraging.
Yeah, absolutely.
Yeah.
I wonder if there yes. In the cornea, there's stem cell derived corneal transplants. That's one.
Wow.
I think in the skin as well, maybe like for skin grafts, wound healing things.
Yeah.
There are a few.
That's amazing.
Exactly, yeah, like regenerative medicine. We should also say that this is not actually the first stem cell derived treatment for type 1 diabetes. There was a previous one. I'll quickly tell the story. There's one patient. This is crazy. They took her adipocytes, her fat cells.
Mm-hmm.
They converted them into stem cells. They reprogrammed them to make stem cells. And then they took those stem cells and they made islets.
I think I've seen that study.
And it's in cell, yeah. And then they put them back kind of under the rectus sheath, which is like here, not on the liver. And it fixed her diabetes, type 1 diabetes.
Oh, it's just mad.
It's really mad. They made islets from fat cells.
It's like, take this, go a few steps back, and then go forward again.
Yes.
That's insane.
Yeah, exactly.
You're seeing more and more of these like N=1 therapies nowadays.
Yes.
Yeah.
Yeah, exactly.
Yeah.
We spoke about it, right? Baby KJ.
Yeah, baby. Oh, we know it's a baby boy.
Yeah.
Yeah. Remember, we didn't know the gender.
We should have known the gender.
Yeah.
Okay.
Wow.
Any final comments?
No, it's just.
I just want to check if I said everything that I wanted to say. Yeah.
I guess we already covered the safety thing, but
yeah,
in all the other 10 patients they were fine, essentially. There were no like adverse events that were too crazy.
Yeah. And that's in the New England Journal.
Yep.
Of Medicine. There we go.
One of your 3.
One of my 3. Don't say that. You can't tell anyone.
Delete that part.
Okay. Last one.
Wow. So what is the last and third breakthrough from Junior?
Oh, am I doing it? Oh,
yeah,
no.
Yeah, you are doing it. You are, right? Oh, gosh.
Okay. So, unless you want to.
No, you don't worry. I'll share it with you.
Okay.
Yeah.
So,
but I think this is more up your alley because like you've been talking about this previously.
So this is So imagine
another paper from New England Journal of Medicine.
Imagine if we had a drug, a cancer drug, which stopped you from getting new cancers, improved survival, stopped you from getting a cancer if you already had one, so stopped cancer coming back, and it had no side effects. Imagine.
Everyone's gonna like sigh when you say what it is.
And it's called exercise. So it's this groundbreaking new therapy called exercise. So someone described it as exorcisumab. Exorcisumab has an extraordinary benefit in cancer.
This is hilarious, but no, it's very important. And like, I'm gonna go to the gym. After I read this, I was like, I'm gonna go to the gym.
Do you know the first thing I did when I read it? I went to the gym. Did an exercise.
So tell us, what did they find out?
Okay, so. It's a randomized control trial, which is, again, of essential importance because we get to isolate the effects of exercise. So exercise is particularly important to do this to do a randomized trial. Because if you just look at two sets of patients and you look at one who is doing exercise and the others who aren't, the one who is doing exercise will also just happen, because of behavioral things, will also happen to be less likely to be smokers, less likely to be overweight, more likely to eat healthily, all of which are anti-cancer, right?
Yeah.
So you don't know whether it's anti-cancer because of exercise or because of these other things.
Other confounding factors. Yeah.
But if we do a randomized trial, you get to isolate the effects of exercise.
Yeah. And this is in colon cancer for patients who've just received adjuvant chemotherapy.
Yes, exactly. Yeah. So it's early-ish stage colon cancer, so stage 2 or 3. They have surgery, they get chemotherapy, which is just standard of care, and then they get randomized.
Yeah.
Either to an exercise program, or just to healthy living advice.
And it's a big study with like 890 patients at 55 different centers. So yeah, huge effort
Massive effort. And
with an 8-year follow-up.
Yeah. It took a while to complete the enrollment, which is a limitation of the approach. But
Now there's no excuse for us to not exercise. They put all this effort in.
Exactly. And the bottom line, what they found is that the exercise group had better overall survival. They had better, they had reduced recurrence of the cancer, which is
So
what they're really trying to
survival.
do. Exactly.
Yeah.
And there was a trend towards fewer new primary cancers, which is it really is a stunning
So
finding.
not just colon cancer coming back, but like any new cancers. And
Yes.
they looked at breasts and prostate cancers.
It really is stunning. And this is the first ever time that a randomized controlled study has demonstrated a benefit on survival in cancer to exercise.
We really have no excuse now to not go to the gym. Wow. And the percentages were like quite striking, because if you look at the 8-year overall survival, it's 90% in the exercise group and 83%. So
It's
7% difference in survival.
It's a really big effect.
Just by exercising.
Yeah.
Because they received the exact same treatment. And I saw that the types of exercise they were doing weren't they were feasible.
Yeah.
As in they were just like they weren't telling you to like do Iron Man or something.
Yes.
They were just telling you like brisk walking, something that gets you sweating, and like 30 to 40 minutes of like cardio a week. So
I mean, basically it's anything you can do that. So if you want to go for a walk, if you want to play tennis, if you want to, I don't know, whatever it is you want to do that, because it's better than nothing.
Exactly. And that's what I like about this trial, because they made it so flexible for the patients. They said anything that increased your MET, which is like a measure of energy use. They went to like a 10 MET hours per week or something. They had a goal, but like you can achieve that in many ways. You can go like swimming, cycling, walking, jogging a few times a week, and that would do it. But I was really impressed by like the organization. Apparently they had to go to all these like mandatory behavioral consulting like sessions, and it was really intense and they did it for 3 years, right?
3 years, exactly.
Yeah.
So it's meant to be at least 3 episodes of exercise per week. Usually it's aerobic. If you want to do weight training, you can. It should be moderate to vigorous. And initially, like you said, it's quite prescriptive. Like it's mandatory. You have to turn up at this time, blah, blah, blah. Mm-hmm. But later on, it gets a bit more free.
Yeah.
And it should be progressive too. So it should get somehow harder over time.
Exactly. And also they made it remote after the first like 6 months. So then you can just report what you were doing as opposed to showing up in person.
Exactly.
Yeah.
But I think that's a key part of it too, because if you just said to these patients, okay, you're in the exercise group, go and do exercise.
Yeah.
Then lots of people wouldn't. Adherence would be much lower. Whereas if you say you have to turn up at 7 p.m. on Wednesday in the gym with me, adherence is much higher, right?
Yeah. Maybe that like we can take a lesson from that and say like, when we want to hold ourselves accountable, we can just give ourselves a more flexible goal. Like just say like just do some sort of exercise. You don't have to like
But with a deadline though, are you suggesting a deadline?
I would suggest a deadline. I think that's the important part.
I think deadlines are very powerful.
we need the deadline. It's like it doesn't matter how you sweat, just like make sure you're, getting your heart rate up and like doing some sort of exercise. And what I like about the study is they made sure that it wasn't the social effects of like being part of this exercise program, because like you get to be you get consulting, you get interactions with these professionals, and they were thinking, is it because you're socializing more? Because people have also studied the effects of socializing.
Interesting. How did
therapy.
they?
And then they said there were other studies that offered like counseling and therapy to cancer patients.
And there's no
effect on
Interesting.
survival in that case. So they were like, it cannot be like a socializing effect. But yeah, obviously it was a mentioned. It was an interesting.
That's very
factor
interesting.
to
But in
consider.
terms of the mechanism is super interesting. So these guys didn't lose weight. Firstly, that's important to say.
Yeah,
The exercise group didn't lose weight. So I would have
that's
expected.
surprising, right?
It's very surprising. So, but it's arguably more interesting because we know that losing weight is anti-cancer, but it shows that you can do exercise and not lose weight and still be anti-cancer, right?
That's great.
And so I think there's two major like molecular mechanisms here.
What's going on?
One is, and this is not these guys didn't prove it, but it is proven. Exercise suppresses inflammation, chronic inflammation. We come back to this before, right? Sometimes
Yes.
we always say chronic inflammation is a big driver of disease. Yesterday I described it as the devil that drives disease, which is, I don't know, that just popped into my head. So
I like that term.
Yeah.
Yeah.
so chronic inflammation is the devil that drives disease, and exercise suppresses it. That's the first thing.
Yeah.
Second thing, exercise is pro-immune system. So these
is.
guys need the immune system to be active because they need to, for example, mop up any micromets or any new cancers that might form, right, or recurrence.
Yeah.
So exercise, it's possibly true that exercise is boosting like the immune surveillance of those new small cancers that are popping up.
Yeah. So like your immune system can better like detect and destroy those cancers. Hence the fewer cases of new cancers in
Yes.
the exercise group of patients.
Yeah, exactly.
Yeah.
So it's like not completely dissimilar from like a vaccine, like an adjuvant setting vaccine,
Yeah.
which is trying to do those things too. So,
Except here you did it without a therapy. It was just
Yeah.
you exercising. You get that sense of like achievement.
yeah.
Yeah, and they found fewer liver metastases as well, which is usually something you find in colon cancer disease. Usually they like metastasizing to the liver.
That's important.
Yeah, and it was mainly breast, colorectal, and prostate cancers that weren't being formed in the exercise group.
Yeah.
So it suggests some sort of mechanism that like exercise can protect you from these specific cancer types.
Yeah. I guess to be fair, those are the most
But those
common
are the most common
cancer
ones
types
as
too.
well.
Assuming
So
these
that's
guys
the
aren't
caveat.
assuming these guys aren't smokers. Breast, prostate, colorectal would be the main three.
Yeah, and they controlled for sex as well. I think they tried to have like an equal number of men and women in the groups.
Yeah. They should.
Yeah.
Yeah, exactly. When they're doing the randomization, right?
Yeah,
Yeah.
exactly. Wow.
So exorcisumab. Fascinating.
I love it. God, I really have no excuse to not go to the gym now.
I feel like now every time you exercise, you get to think, wow, this is reducing my risk of cancer.
Yeah. Also, can we talk about the hazard ratios? I love looking at hazard ratios.
Do you?
Yeah.
Yeah, I'm game.
Because of Cristiano, our good friend.
Okay. He likes hazard ratios?
He loves hazard ratios.
Really? Okay.
So the hazard ratio for, if you look at the reduction in risk of recurrence, it's 0.72, which means there's a 28% reduction in your risk of getting a new cancer or death
Yes.
from cancer. And then the overall survival, the hazard ratio there is 0.63. So exercising gives you a 37% reduction in risk of death. Yeah. Crazy.
That's amazing. Yeah.
Yeah.
I guess it makes sense that it's slightly bigger for overall survival because these guys exercise will also reduce your risk of things like heart attacks and strokes.
Yeah.
Like
And
cardiovascular
they're
disease.
an older, probably an older population of people as well.
exactly.
So yeah, my goodness. What an exciting June.
So
Sleep better, get your therapies early in the morning, and exercise. It's like stuff we already knew.
that's true. It's nice, but that's true. And so if you try to communicate these things, like I try to do, right? If you try to communicate, then people will say to you, yeah, that's obvious. And I guess maybe it is obvious, but unless you have the data to prove it, is it obvious? I mean, I would never, if there's no data to underpin the finding, I would never call it obvious.
But now there's like a strong RCT.
Yeah. And by the way, some people don't believe the RCT. So
What?
You're
Why not?
You're down,
Okay, I need
you're
to know
down if you
this.
do,
Why?
you're down if you don't.
Why wouldn't they believe the RCT?
Because of they don't, what you alluded to at the start, the very, very long time it took to recruit patients, plus the some kind of technical statistical things as well.
Okay, so the nerds are like arguing about the stats.
But I would say I would definitely err on the side of exercise because it's harmless. So we know it's good for you. We know it's harmless.
We know it makes you happy.
Exactly.
Yeah.
So it's not like we're advocating a drug here or cancer drug, and you know dangerous cancer drug.
Yeah.
We're not. We're advocating it's exercise, right?
Yeah. Honestly, I'm gonna print this out and like
you want this
motivate my. Can I? I'm gonna motivate myself to go to the gym more.
Yeah, exactly.
Wow. So Sam, would you like to do the honors of summarizing the 3 studies?
Okay. So the first one is that it's possible, or maybe even probable, that immunotherapy is better in the morning.
At least for non-small cell lung cancer.
Non-small cell lung cancer. The second one is a stem cell derived islet therapy that is towards a cure for type 1 diabetes.
Amazing.
And the third one is that exercise is a miracle anti-cancer drug.
I will go to the gym after this. Well, thank you so much.
And the sun came out as well.
Yeah. Gosh, so giving. The UK. So uncharacteristic.
And Wimbledon's on here as well, on today as well.
And women's football.
And the women's football. You know who won the women's Euros last time?
Oh, who?
England.
Really?
Yes.
Last year? No, 2 years. Is it every 2?
4.
4 years. Oh my gosh.
It's the Euros, right? Not the World Cup.
Yeah, it's Euros.
I'm pretty sure we won it last time. I think that's
Can you
true.
tell I don't watch football?
Okay.
Soccer.
Tiff, it was nice to see you.
Good to see you, and see you all next time for the biotech deals in June 2025.
Okay. Ciao.